Hello and welcome to Corneal Dystrophies and Degenerations. This is Dr. Isha, and my YouTube channel goes by the name of My Opthal Teacher, where you'll be finding all my presentations. So, when you want to understand the dystrophies and the degenerations, you have to know about the anatomy of the cornea. So, as we know, these are the main layers of the cornea, that is the epithelium, basement membrane, Bowman's, stroma, descemet, and endothelium. Between the stroma and the descemet is a pre-descemet layer or the Duas layer. So anything that affects the epithelium, basement membrane, and the Bowman's is going to cause recurrent corneal erosions, right? So most of the epithelial and Bowman membrane dystrophies present with recurrent corneal erosions. Anything happening in the stroma over here is going to lead to a corneal opacity of varying degrees depending on the depth up to which it is involved. And anything that affects the endothelium is going to cause corneal edema. Why? Because the endothelium has the sodium potassium ATPase pump, which maintains the cornea in a state of relative dehydration. Dystrophies of the descemet membrane are not known yet. So the basic difference between a dystrophy and a degeneration is that dystrophies are usually inherited, bilateral, and they may present in childhood as well as adulthood. They usually affect the central cornea. Degenerations, on the other hand, are seen in older people. They are mostly affecting the peripheral cornea. They may be unilateral or bilateral, and they happen because of some long-standing condition of the cornea. So that is the basic difference between the two. Coming on to corneal dystrophies, the IC3D classification, which is based on the anatomy itself. So epithelial and subepithelial dystrophies, as I told you, epithelial dystrophies are going to present with recurrent corneal erosions because they involve the anterior-most layer of the cornea. Generally present in adults. Asymptomatic or recurrent corneal erosions. If there is a corneal erosion, there's going to be pain, lacrimation, blurring of vision, and repeated episodes is going to cause varying degrees of corneal haze. Corneal haze because the pathology is still in the epithelium or maybe the Bowman's layer. They include the three main epithelial basement membrane dystrophies, that is the Cogan microcystic epithelial dystrophy, also known as map dot fingerprint pattern that you see here, Meesmann corneal dystrophy, which forms these small cysts that you see here, and gelatinous drop-like dystrophy, which appears like this. These are the main epithelial and subepithelial dystrophies, although there are several, but I've described the three main types, the most common types for you here. Now, when there is a dystrophy, there has to be some pathology in the, when you look at the histology of a PK specimen. So here we see that there is a thickened basement membrane, and as you know, all basement membranes stain positively with periodic acid shift or PAS stain. I'm going to put these blue colored boxes on all the slides, and they are very important for your MCQs as well as your Viva. Coming to Bowman's layer, which is the next layer, these dystrophies are usually autosomal dominant, present in childhood, again with recurrent corneal erosion and varying degrees of corneal opacities. There are two very important main dystrophies, that is the Rees-Buckler corneal dystrophy and the Thiel-Behnke corneal dystrophy. So I've shown you the Rees-Buckler corneal dystrophy over here, and the histological section shows focal absence of basement membrane in these of the Bowman's membrane in these areas, and irregular thickening of the epithelium, right? So what is the stain here? There is a hyaline protein deposited on the histological section, and this stains positively with the Mason's trichrome. This stain you'll also come across in some other corneal dystrophies as we proceed. Now, these are the two main dystrophies, and remember they have a number of synonyms. It is advisable to remember these synonyms. Remember, Rees-Buckler is also known as atypical granular dystrophy. Coming on to stromal corneal dystrophies, these you have to know in a little bit of detail. There are three main dystrophies. They are also the most common type of dystrophies. They occur around puberty. They form discrete areas of corneal opacity as we discussed in the first slide. They are in the form of deposits between the corneal lamellae, okay, which are made up of collagen fibers. And gradually these deposits increase in number and density until they lead to poor visual acuity. So usually a corneal opacity takes time to develop, hence the late visual deterioration that is beyond 40 years of age. So there are three main corneal dystrophies. Let us discuss the granular dystrophy first. So this is autosomal dominant. See, it is affecting the central area. And these areas have clear cornea in between. So that is a typical feature of granular dystrophy. What is the stain? It is again the Mason's trichrome stain. Hyaline protein is deposited on the cornea in between the lamellae, as you can see here. Lattice dystrophy. Now you see these crisscross lines in the central cornea looking like a lattice. So that's lattice dystrophy. What is deposited over here? Amyloid is deposited in the stroma, and in pathology you will read that amyloid deposits stain positively with Congo red stain, and this is a picture of birefringence which is seen by amyloid. Macular dystrophy, now remember this one is autosomal recessive. Also, opacities do not have clear areas in between, unlike the granular dystrophy. You see, these are the deposits, very dense deposits, and slowly they involve the endothelium and the desmet also. You can see that they involve the endothelium here. And what is the stain? Colloidal iron stain, because the deposits consist of GAGs or glycosaminoglycans. Endothelial corneal dystrophy is the last one. Now, there are several, such as CHED and PPMD, but Fuchs is the main dystrophy which you cannot afford to forget. Now, these are rare. Fuchs is the main one. It is seen in elderly females. What happens is there are hyaline excrescences formed on the desmet membrane, which is just above the endothelium. These are known as the corneal guttae, and they ultimately lead to endothelial cell dystrophy. When the endothelial cell dies, there is edema of the stroma and gradually even of the epithelium until the entire cornea is opaque, as you can see here. Symptoms include halos in the morning, episodic pain, secondary infections. Halos in the morning, why? Because on waking up, the cornea has been in a dehydrated state overnight. There is in a hydrated state, overnight, because there is lack of evaporation of the tear film. Hence, the corneal edema is worse in the morning. Episodic pain and infections, why? Because there is also epithelial edema in these cases. So, epithelial edema is characterized by bullae, and when these bullae rupture, they lead to pain and infections. Ultimately, the cornea looks like this. The temporary treatment, is hypertonic saline. For the epithelial edema, it provides temporary relief. And of course, the definitive treatment is a penetrating keratoplasty, is and has always been the gold standard. The hyaline excrescences stain positively with PAS again. So treatment of epithelial and subepithelial corneal dystrophies is the treatment of corneal erosions, blunt dissection manually, or phototherapeutic keratectomy, PTK, in which the laser is used to clean the deposits. Stromal dystrophies, penetrating keratoplasty, because they are going to affect vision later on in life. Endothelial, temporary, again, hypertonic saline, permanent, PK, is and has been the gold standard. And the newer surgical techniques include DSEC and DMEC, which are a type of lamellar or partial thickness keratoplasty in which only the diseased layer of the cornea is changed. Let's move on to corneal degenerations. So they may be primary or secondary. This one's our favorite, arcus senilis, a very, very common corneal degeneration, which consists of lipoid deposition in the peripheral cornea in a band of about 1 mm. Remember, between this band and the limbus, there will be a zone of clear cornea known as lucid interval. If the same thing happens in young people in less than 40 years of age, it is known as arcus juvenilis, and it warrants a serum lipid profile to rule out hereditary causes of hypercholesterolemia. Remember, these degenerations are always going to have a lucid interval. So this one is Terrien. Now, Terrien is basically a progressive thinning of the cornea, as you can see in the slit over here. It is usually bilateral, more common in men, asymptomatic initially, and gradually this thinning becomes a pannus, a vascularized pannus, and even minor trauma may give rise to perforation of the cornea. This kind of thinning, if asymptomatic, is at least going to lead to astigmatism later on. Band-shaped keratopathy. Now this begins at the sides, that is at the temporal and the nasal limbus of the interpalpebral region, and gradually progresses centrally to involve the central cornea and become a band-shaped structure, hence known as band-shaped keratopathy. There are some ocular conditions associated with chronic inflammation that cause this band-shaped thing, and there are systemic conditions. It leads to the appearance of a whitish band in the interpalpebral area that begins from the sides and progresses to involve the central cornea. There will be a lucid interval. There is deposition of calcium salts in the superficial stroma. That is what this band is about. And the treatment consists of surgical scraping or chelation using EDTA, which is the chelating agent for calcium, or phototherapeutic keratectomy, because these deposits are quite superficial. Climatic droplet keratopathy is seen in people who work in extremes of temperature and dry climate, and this is what it looks like. You see, it looks like a gelatinous drop on the cornea. Again, it is a superficial deposit and it can be scraped off manually or using PTK. There is a lucid interval, although this one you see is involving the central cornea, right? And also known as oil droplet or actinic droplet keratopathy. Next is Salzmann nodular degeneration, usually seen in the form of a white gelatinous nodule, secondary to some long-standing corneal disease, such as chronic keratitis. It is slowly progressive. The treatment is lamellar keratoplasty. Again, just the superficial layers of the cornea are involved and they can be transplanted. Note that hyaline infiltration, lipoid changes, and calcification are all degenerative changes that can also be seen in old corneal scars or anterior staphylomas. So you can find my presentation on the YouTube channel, My Opthal Teacher, and thank you for listening.